Alright, we're gonna record this too so I can put it on that website. Hopefully I'll do it today or tomorrow so you guys, if you're studying, you guys will have these if you want. So lesson number 13 is placing sealants and home bleaching. So that's what we'll be doing today. We'll be placing sealants, polishing, and we'll be making your bleaching trays on the models that you guys took impressions of earlier. You'll be trimming the models and then putting the block out on half. I don't know if they'll have you do on all teeth or just half the mouth, and then you'll do the suck down and cut those trays. So lab session 13. So placement of the pit and fissure sealants, and we've talked about these on the pediatric lecture and even before that. Yeah. Organized.
We normally start with the lecture.
Oh, what is this? Oh, my bad. No. Sorry. I thought I had the right one.
Get organized.
I know. Jeez. Okay. Jeez. My bad. Ortho. Sorry. Rewind. My bad. Apologize. Because we were talking about polishing and all that. Anyway. Alright, so rewind. Orthodontics. Lecture 17. Alright, so everybody knows orthodontics, what they are. We're placing braces on teeth. So that's one of the specialties that exists in the dental profession. So the dental specialty, which focuses on the growth and development of the dentition and its surrounding anatomical structures. The specialty deals with prevention and correction of dental and oral deviations. Orthodontists limit their practice to the correction of malocclusion and straightening of teeth. So once you hang your shingle out as an orthodontist, that's pretty much all you're doing is correcting a bite. Okay, you don't do any fillings, or you're not supposed to do any fillings or anything like that. Alright, so what causes some of these malformations? And some of these are genetic. Nothing you can do about it, just your mom and dad gave them to you. Okay, so I just saw one of my nephews, or my wife's nephew, a couple days last week, and referred him. And so, I mean, he just has, his lower jaw is just too big for his upper jaw. So he's got a bilateral crossbite. So his upper jaw is narrow, his lower jaw is wider. So they've got to do some stuff. And I just took a couple of his teeth out on Wednesday, I think. So again, some of this is genetic. So jaw and teeth discrepancies. Your jaw is bigger, or your teeth are too big for the space of your jaw, or your jaw is too small for the size of your teeth, whatever it may be. Sometimes you have clefts, and you've seen patients that may have a cleft lip, or there's a cleft palate.
The office that I'm shadowing at is just general dentistry, but they do braces.
I'm starting to do braces myself.
So you can do
As
that.
a general dentist, that's what the beauty of general dentistry is. I can do root canals, I can do extractions, I can do whatever as a general dentist. Now I have my limits, and the ortho cases, I've got two that I'm starting on. I've taken training and I'm going to start doing them. They're very simple cases, you know, just rotating a front teeth. I'm not doing any eruption or anything like that. I'm just realigning basically anterior teeth. So they'll take, you know, probably less than a year to do. And so I'm going to start doing that here first part of June. I got all the stuff. So yeah, you can do them. Invisalign, a lot of dentists do Invisalign, or there's another one, clear something it's called, where you have, again, minimal tooth movement, slight rotations, where you use the clear trays, like retainers, and they'll rotate your teeth. You know, all you're doing is you're putting like composite on certain areas of the teeth, and you pop in that retainer, and that composite puts pressure on the tooth, on the retainer, and it starts to rotate it. And then you, after that stops rotating, you change the retainer and it puts more pressure, or you change the composite wherever you put it, and it slowly starts to rotate the teeth. You create space by sometimes stripping the teeth, just kind of narrowing the teeth down to create the space to have it to rotate. But yeah, there's no problem as long as you're not doing stuff that you're not supposed to be doing. So now if I get started and I see that it's too difficult or I don't want, then I can just stop. But again, going back, some of these are genetic, so teeth are too big or jaw is too small or whatever, facial or palatal clefts. Again, a cleft is missing bone. You know, genetically your jaw didn't join or fuse together here, so you end up with a space, sometimes missing teeth. I did a big case a couple of years ago. A patient had, you know, he was 19 or 20 now, but throughout his life he had, I don't know, 7 or 8 surgeries, you know, to try to correct a cleft inside and the tissue on the outside. He looked pretty good. But at that stage, now he was ready to restore his teeth, so we did some bridges and did some. They wanted to do implants, but the bone never really wasn't healthy enough to take an implant, so we ended up doing bridges. Your tongue may be too large or too small. Okay, the tongue is a big muscle. If you have a narrow tongue, then your lower jaw is going to be, you know, narrow. If you have a big tongue, your tongue is going to expand that bone. Okay, so the tongue does a lot to move the bone as you're developing. Again, if you remember when we talked about the bone, the synthesis right here is cartilage. And if you have a big tongue, you know, that before that bone fuses, it's not going to allow it to come together and be narrow. It's going to keep it wide. Okay, so a lot of that is dependent on your anatomy and your muscles. Development, again, really strong muscles on the outside or frenums on the lip, again, will pull or tug or expand or put pressure on this as you're developing. So all these are the genetic that, you know, the kid has no control of. And we'll look at some of these here down as we go on. But again, I think there's, look at your study guide. Do you need to know 3 of these, or I don't know if all 4? Systemic influence. Okay, some of these things are systemic. You may have an infectious disease, endocrine disturbances, nutritional disturbances that play a role. For instance, a high fever during development can affect a tooth bud formation, causing the tooth to be malformed. So you may have a tooth, when the tooth bud was forming, either your mom or yourself had a high fever, so the tooth bud didn't form right. So what's that going to do? You're going to get a malformed tooth which may be narrower, okay, or may be deformed. And when it comes in, you know, it's going to be in the wrong spot, or it's going to be too little. I think somebody has a peg lateral. Yeah. So a peg lateral here, we have Vanessa, I've seen. Luckily, it's in the right spot, and that's easily to correct, you know, with a veneer or a composite. I can do that for you if you want, anytime if you want. Somebody can assist, and you can get it for free. So.
Okay.
One of the perks of being in the school is catch me at a time that I'm not working and have somebody assist. And we can get it done. All right. So again, that'll cause some, and that peg is just genetic. That's not because you had a fever. That's just your mom may have it or your dad. Nobody, brother, sister, missing premolars. None of them. And then you may pass it on to your kids. But that's not uncommon. Early or delayed loss of baby teeth. Okay, if you lose a baby teeth early, what happens to your permanent teeth? They drift. Or if you have a big cavity on your baby tooth, what happens to the permanent tooth? It's going to drift into that cavity space. Early eruption of permanent teeth. Okay, if you get a permanent tooth that comes in before its time and the baby tooth isn't lost, or it is lost, this tooth is going to come in and tip before this other one comes in, so it's going to cause some crowding. If you lose a permanent tooth, that wasn't supposed to be lost. It's gonna cause moving and shifting of your other teeth, or tipping of your teeth. Gum problems causes teeth to get loose. Again, if you've got gum problems, your tongue is a muscle that's gonna flare your teeth, okay? Because your tongue is so strong. Or your teeth will get loose and just start moving. Also, the muscles on the outside may cause them to come in on the upper. We saw some of these pictures when we did x-rays, or what picture it was, but these cysts will start to put pressure on the teeth and start to move the teeth. Okay, so if you get a tooth that all of a sudden starts going this way, it may be some growth underneath it that's causing it. Injuries or trauma, again, that you get somebody that hits the bicycle and knocks the teeth back, they'll be reimplanted in there, and they're going to stay back, and they've got to move them out. And these are the big ones, thumb sucking and tongue thrusting, okay, that you see a lot of the kids that come in and they're thumb suckers, and you end up, oops, I had a thumb sucking thing, I'll show you right now. And tongue thrusting just means that when a kid swallows, or when you swallow, some of you guys may be tongue thrusters, when you swallow, normally your tongue goes on the roof of your mouth. And who was it that was asking what those rugae were last week? Rough on the palate. When you swallow, your tongue goes on the roof of your mouth, and those little ripples on the palate are called rugae, and they're there because your tongue, when you're speaking, it actually knows where to land on those, and so that's how you pronounce some of the letters, some of the different pronunciations, because your tongue either touches the first one, the second one, or the third one, and that's what it's for. If you have a patient that has a denture, dentures are usually smooth, and sometimes we'll make them with rugae. The denture will be a little rippled up there for that reason. When a patient gets a new denture, they speak a little bit funny because their tongue doesn't know what to do. So it's just that, other than just being a big piece of plastic in your mouth. Okay, so you lose a baby tooth with no roots here, and that's what we want. Okay, this tooth is coming in, everything's good. You know, this tooth isn't gonna tip. But if you lose it prematurely here, and this tooth back here, this 6-year molar, is going to start to do this. So here, this tooth was lost. You got a developing tooth down here, and we should have put a spacer here back with a distal shoe to keep this tooth from tipping forward. Now you got a big mess. To try to upright this tooth back is going to be a lot harder than if you just put a space maintainer like your son. Aiden? Okay, so again, early loss of deciduous tooth, mesial tipping of the first molar, impaction of the second permanent premolar.
I have a
Okay.
question.
Yes.
So my niece, she's not going to be getting her canine teeth. So does there like...
What number is her canine teeth? 6 and?
No. 11?
And she's got 4 canines. 6'11".
There's 7 and 5.
2.
Okay.
6'11", 22, 27.
Okay. So if those, like she's not ever hit those, so does a gap, like will there be a gap?
How old is
Will
she?
the teeth be like, she's 9.
And she doesn't have any of the canines? They're congenitally missing?
No, like will there be a gap or will there, like her teeth just...
So they're not there, they never formed. What's being done now is they're bringing the premolars forward. So once, if she doesn't have them, that's the best thing to do. Just bring the premolars forward and close the space.
Get
Implant?
yeah.
If she's that age, do you want to hold that space for, because she can't get her implant until she's 20, 21 or something like that. So you're going to have a spacer there for, whatever, 15 years, or no, just have braces and bring the teeth and close it, you probably won't even notice. Now sometimes the lateral is missing, and that's more common when you're missing a front lateral that is congenitally missing. So you lose the baby tooth and you end up with a space here in the front. And you can hold that space. I've got a case right now that I'm holding with a composite filling and a little Gore-Tex membrane in the back, just as like a Maryland bridge. That Maryland bridge is the one that you bond behind. And the kid, he is 16, I think, and that's what they wanted. If it was my kid, I would have, and that's what the orthodontist recommended. If it was my kid, I would have brought the canine into that space, and then I would have made that canine look like the lateral. Okay, I would have shaved down the canine and put a veneer on it. Okay, better than waiting, because he's not going to be able to get his implant till he's, you know, boys stop growing till whatever, 22 or whatever. That's when you can have that implant. You can't place an implant if you're still growing. So if it was my kid, I would have closed it, brought the canine in, and then I would have made it look like a lateral. But they chose the other route for whatever reason. So that's what I would do on her. Again, you lose a permanent tooth, you're going to get spacing. Okay, the teeth are going to drift. Okay, so habits. Those were genetic or induced by premature loss of teeth. Now these are habits. Okay, the biggest one is thumb sucking. Now prior to the age of 5, if you have a child that's beyond or younger than 5, it doesn't really cause it. You know, nothing really to worry about. You know, let your child. It's fine. It's a comforting thing. You know, try to get it to break the habit, but it's hard. It's hard to do. You know, try to do positive reinforcement. You know, get them to avoid it. After the age of 5, then we start to see a problem. Okay, you start to see the palate being pushed up under the nose. The upper arch starts to become narrower, and that's when we see a problem. Okay, maxillary arch and anterior teeth, and the anterior teeth begin to kind of buck teeth. Again, tongue thrusting is when your tongue starts putting pressure on your teeth instead of up on the roof of your mouth when you swallow. You swallow and the tongue does that. Okay, I'll show you a
My
picture.
daughter's a thumb sucker and her top teeth are pretty crooked.
It's common. Yeah, again, because if you think about it, how old is she?
She's 3.
Oh, she's 3?
Yeah.
I don't know, at that age, that may be some genetics. Okay, when they're older, because at 3 she's barely getting her baby teeth in. So it may be causing some rotation. I'm not sure. But usually when the permanent teeth start coming in by age 5 and 6, then again the bone will be deformed by that time, and it does cause a problem. Bruxism is just grinding, clenching and grinding, and we see some kids that come in and their teeth are like flat to the gum. They just clench and grind at night. Nothing you can do. It's just you want to kind of wear them down before they go to bed so that they're don't have too much energy while they sleep.
Would a mouth guard help with that?
Not at that age, because things are still moving. I mean, you can make a mouth guard every month. You know, at that age, until they have their permanent teeth, then you may be able to do anything. But you know, they're growing, their jaw is growing, their teeth are moving. So again, this age, nothing to worry about. This age, we start to worry about. Okay, so after age of 5, we start to worry about it. Again, if you think about it, the tongue here starts to put pressure on the thumb, and you start to force these teeth up forward and the palate up underneath the nose, and you end up with, you know, something like that. And it's not just the aesthetics. You know, once they get into grade school, you know, kids start making fun of these kids. You know, buck teeth or whatever they start, Bugs Bunny. You know, I remember all that. You know, not that it was me, but I remember other kids being called that. But it just begins just starts to to affect their self-esteem. So it's really, really good to try to prevent this if we can. And you know, sometimes some of these kind of barbaric things are placed in there to try to avoid it, but this is the best thing to do. But kids, sometimes I've had kids with these in, and they still find a way to get around it. You know, it's hard. You know, you just try to place this in, and again, just work with the kid, positive reinforcement to try to get them to break the habit. You know, they sell these things. These, yeah, these usually don't work. They'll start sucking another thumb, another finger. This is usually what works best. Something that they can't.
My son broke his arm, and that stopped it.
And that, well, yeah.
It was so sad, because he was in a cast up to him.
And he couldn't break it. Oh my gosh, yeah, you can imagine.
It was really sad.
Yeah. So, there you go. It's another solution. And here's tongue thrusting. Okay, it kind of does the same thing. They swallow and the tongue comes up, and again, the tongue is powerful. It's going to push those teeth forward. And you've probably heard, you know, some patients talking, and you see them how they pronounce some of the words, and again, the tongue when you talk should be up on top. But some patients talk and they use their teeth. They bring their tongue forward. For tongue thrusting, we have some of these appliances, these little rolling balls there. Or again, if it's really bad, you could put these little hooks, sharp hooks there on the bottom, to try to avoid the tongue to come in there.
Oh my god.
Yeah, it's not fun. Again, sometimes these kids will grind at night, and this isn't.
Doctor, there's someone up there.
Oh. Yeah.
I grind my teeth.
So again, this sometimes you see them flush with the gum. So this isn't terrible here, but again, you can see how they just ground their teeth. So they say that you're supposed to, you know, just make sure the kid is really wound down by the time they go to bed. Because usually when they go to bed and they're still kind of hyper and stuff, that's when.
Really?
But again, it depends on who you read. Some of the literature there just says that it's. The other thing, new literature that's coming out is some of these kids that do have this, they start to relate it with sleep apnea at a young age. Because when they can't breathe, they start to grind their teeth. It's just a reflex. And so they say sometimes when we see this now, we need to refer them to an ENT doctor, ear, nose, and throat, to evaluate their adenoids. Okay, because they may not be getting the proper air when they're sleeping, and that may be causing this as well. So that's something that I just heard about probably a year ago at a course. So that's another possibility. So a few things that could be. Okay, so again, the orthodontist, this is what they correct or deal with. The occlusion, which is the bite. And if it's not right, if it's not the right occlusion, it's the malocclusion. Okay, know that, that's on the test. Malocclusion. The entire form of function of the face and its structures are directly affected by the manner in which the biting surfaces occlude, or how they come together. The development of occlusion is an ever-changing process that continues throughout life. Again, as we grow older, we're wearing down our teeth. The bite is changing as you know throughout life. It's not you get your bite and that's your bite forever and ever. It doesn't. You may get a filling. You may, again, your tongue moves teeth. You wear your teeth down. The bite changes. It's not a static. That's the word on the test. Is it static or not? It's an ever-changing process. Okay, so there's such a thing as ideal static. Ideal occlusion is the perfect occlusion. And is there such a thing? not really. You know, everybody's, as long as you're functioning and there's no problems with your teeth, that's your ideal occlusion. But in the literature, the ideal occlusion is the maxillary teeth are in maximum contact with the mandibular teeth, okay? So if you get your models, when you get home, put your yellow models together and you mount them the way they come together best, that's the ideal occlusion, that's the maximum contact, okay? When they're in maximum contact, there's a 2 millimeter overlap of maxillary teeth and the maxillary anterior teeth and over the mandibular anterior teeth. Maxillary posterior teeth are one cusp buccal to the posterior teeth. So I don't have models here, but again, how they come together, your upper teeth are 2 millimeters in front, and on the side, the maxillary cusp is one cusp out. Okay, so if these are your upper, it goes like this. You know, the buccal cusp is on the outside. If they're reversed, then you have a crossbite, okay, where your bottom cusp is on the outside. It should be buccal. Upper cusp is buccal all the way around. Okay, so put your models together and look at that ideal occlusion. Oh, there we go. Why am I talking? I got models right here. Okay, again, 2 millimeter overjet, and your maxillary cusp is buccal to the lower cusp. Okay, so if the bottom are reversed, then you have a crossbite. And we'll talk about that here in a bit. Okay, so here's in the mouth. This is an ideal occlusion. Okay, canines. Yes.
I have a question because I have the same thing. My canines are yellow compared to my other teeth.
Brush your teeth.
I do. I floss too. I don't know why. It's like mostly my canine.
That
They're
is
yellow.
everybody's. Everybody's canine
It's
is
so
usually
weird.
darker.
Oh.
Everybody's canine is usually a shade darker than your central
When I
incisor.
see that, I'm like, that's how my teeth are.
Yeah,
Why
is
is
that?
that?
It's so weird.
it just is. You know, teeth color is like hair color, eye color. You know, your teeth color are, if you want to bleach them like you dye your hair, you can bleach them, but it's going to come back. It's not, if you whiten your teeth, it's not going to whiten, you know, forever. You've got to keep whitening them and maintain, just like if you do something to your hair, you got to keep touching up the roots of your hair. It's the same thing with your teeth. You know, it's like your hair color or your eye color. That's your color. You know, it's, again, genetics. Here's an ideal occlusion. This is what we want. When you bite down, you want, you know, little dots. This is ideal. Does everybody have that? No. I don't find any patients that. This is on a patient that was probably equilibrated, you know, probably having joint problems or something, and they went in there and ground down so that they had this ideal occlusion. And that's, you know, that's how you should contact on the buccal cusps of the bottom teeth and on the lingual cusp of the upper teeth and on the central fossas. So ideally, but you don't find this very often. Centric occlusion is another occlusion. So that's ideal occlusion. 2 millimeters forward and the buccal cusp of the upper on the outside. Centric occlusion, and this is more, well, we're talking about the joint. Okay, maxillary and mandibular jaws are closed. The teeth are in maximum contact, which is centric occlusion, or maximum intercuspation. And the heads of the condyles are seated as far back and up in your jaw. And what was that fossa? What was that fossa called? Remember? Glenoid fossa. What bone?
The temple.
Yeah, oh my God, nice. So the glenoid fossa of the temporal bone. Okay, this is what we're talking about. Both condyles are in the most retruded and unrestrained position in the glenoid fossa. Oh, it says right there. That's cheating.
I didn't read it.
Yeah. All right. All right. So what's malocclusion?
A bad occlusion.
Bad. Malo. Everybody know Spanish? Malo. So bad. Malo means no good. So bad occlusion. If it's not ideal occlusion, it's malo. So bad occlusion. So any deviation from normal pattern occlusion, okay, is malocclusion. So if you don't have the ideal, then you have some sort of malocclusion. And I think that's 90% of the population. You know, or you have an interference, or you have a slightly rotated tooth, or you have a little flaring of a canine or a premolar. I've seen premolars that are reversed. I mean, there's some sort of malocclusion. Okay, what can they cause? It could cause or impair chewing, mastication. Okay, it could increase the susceptibility of caries. If you've got crowding, you're not going to be able to brush or floss as thoroughly. Okay, so it could increase the caries down the road. Too much crowding on your lower teeth, you've got very thin bone between teeth, and so any type of gum inflammation, that bone is going to go down real quick, so it'll increase the possibility of gum disease. And if you increase the possibility of gum disease, possibility of early tooth loss. Okay, so that's why braces aren't just an aesthetic concern. You know, we're trying to look, especially in kids, we're trying to prevent further complications later on from them getting into gum disease or gum problems or high caries. And again, this we talked about just affects the self-confidence or the self-esteem because of, you know, their teeth being flared out or missing a tooth or whatever it may be. This is another one, it could impair speech. You know, if your teeth are too flared out, you're going to be, you know, lisping, or if they're too far back, you don't have the proper tongue space, you know, it affects how you talk. So orthodontists deal a lot with speech therapists as well. You know, if they have, especially if they have a tongue thruster, they'll tell that patient, right, or the mom, you know, I'm going to correct the bite and I'm going to get it to where it's at, but we have to break the tongue habit because it's the tongue habit that's causing it. And even if they're in retainers later, they get their tongue, if it's not properly trained, it's going to want to do the same thing. So they start doing speech therapy while they're in braces. Okay, classifications, and this kind of gets a little bit confusing, but this is on the test. Okay, so this is how we classify the bites, okay, or the bad bites or good bites, based on the maxillary and mandibular first permanent molar. Okay, so class 1. Profile, remember that. Mesognathic, okay, is your straight profile. So I'm not class 1, I've got kind of a curved profile, okay. So patients with a straight profile, let's see who's got a straight profile. Rebecca's kind of drew a blank with your name here. Miranda kind of have a straight profile. Jessica has a straight profile. Okay, so it's pretty, and how they do it is they take you measure here, right between the eyes, underneath the nose, and your chin, and you draw those 3 points, and if they're straight, then you have a straight profile, and that's what they look like. Okay, your bite is considered neutral occlusion. Molar relationship, mesiobuccal cusp of the maxillary first molar is aligned with the buccal groove of the mandibular first molar. So here's kind of what we look for. Okay, right between the eyes here, the nose and the tip of the chin here, and it should be, I think the angle they say is like 165 to 180 degrees, or less than 165 to 175, I think what it is the angle that it'll make. If you put a dot there, and a dot here and connect them, it should be a really slight angle. So that's mesognathic. Okay, that's class 1. So meso, class 1. So you're going to remember it. Meso, class 1. These are on the test. Okay. So your bite is neutral occlusion, meaning your mesiobuccal cusp of the first molar is in the buccal groove of the lower first molar. Okay, so, and you don't have your models here, but when you get home, look at your mesiobuccal cusp of the first are those in the back? Do you guys have these images?
Yes.
Yeah. So again, the mesiobuccal cusp of the upper jaw comes into the buccal groove of the lower first molar. Okay. So if you look at this patient here, same patient, again, mesiobuccal cusp comes right, here's the groove, the buccal groove of the lower first molar, and it comes down and hits right there. Okay, so class 1 occlusion. And that's what? Mesognathic, means you have a straight profile. Class 2 profile is retrognathic, which is me. Okay, I'm class 2. I got a weak chin, big nose, so if you draw here, 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 I've got a bigger angle. Okay, so profile retrognathic is a weak chin. Okay, so retrognathic, class 2. Retrognathic is the word you need to know. Okay, so disto-occlusal molar relationship, mesiobuccal cusp of the maxillary first molar is a line between the mandibular second bicuspid and the first molar. Division 1, and then there's, you can break it up, you don't need to know these. Division 1 anterior or overjet in the maxilla. Division 2, the laterals kind of come forward and the teeth are back. So in Division 1 it's like this, in Division 2 they're like this, but you need to. Okay, so this is kind of me here. Okay, between the eyes, the chin, and then, the nose and the chin, you kind of have this bigger curve. Okay, so that angle is going to be a bigger angle, or a smaller angle. So retrognathic weak chin. Okay, that's class 2. Okay, and again, now my bite, because of braces, my bite isn't like that, but if the braces hadn't have been done, then it would look like this, where your mesiobuccal cusp hits in front of the first molar and distal to the second premolar. So in class 1, this cusp is back here in the buccal groove, but in class 2, because your chin is back, okay, the mesiobuccal cusp falls one cusp forward. Okay, so something like this. Here you have the mesiobuccal cusp, and it falls in between the molar and the premolar. Where this, in class 1, this cusp is back here, where this one is. You guys see that? And but by this jaw being forward, and the lower jaw is back. So you've got more of an overjet. Instead of 2 millimeters, which is the ideal, you're probably going to have 4 or 5 millimeters underneath your front teeth, and so you're going to be more like this instead of like this. So here you go. So he would be class 2. Okay, so again, from the here, the tip, the edge of between the eyebrows to the underneath the nose to the chin, and you draw that angle, and you're going to have a smaller angle. This guy had surgery and had a jaw advancement, so now he's more. What's class 1? What's the name of class 1? Mesognathic. Okay, this is retrognathic, meaning back. Retro, back. Meso, like middle. Okay. What would be the next one? Prognathic, like Jay Leno. Okay, prognathic is a prominent chin. Okay, bulldog appearance. You don't really, the molar relationship, mesiobuccal cusp of the maxillary first molar is a line between the mandibular first and the second molar. So the mesiobuccal cusp is now behind the lower first molar, not in front. Okay, so here's the maxillary first mesiobuccal cusp. In class 1, it's here, right on the buccal groove. In class 2, we're over here. But in class 3, and this is real common on Asian, where the lower jaw is reversed. So you're going to have your lower teeth in front of your upper teeth. Okay, so you got like a cross bite all the way around. Okay, you can see how the bottom teeth are in front of your upper teeth. Okay, so this is prognathic, prominent chin. So meso, retro, prognathic. That's how you're going to remember. Everybody gets them wrong on the test, so don't get them wrong. Trying to find the ways that.
Is it this that's on the test, like these ones, or is it all of it? Like you have to match them, basically?
Well, I think, does it fill in the blank?
No.
No, they're not filling the blank. I was trying to remember the question. It just says, no, I think they're multiple choice, and it says a patient that has that's mesognathic with, and it'll say the occlusion, but, you know, just remember meso is class 1, prog is class 3. You can learn, I don't know if it may have,
Like, do you need to know this part?
I would. And just learn that where the first molar is. First molar mesiobuccal cusp is on the buccal groove, your meso. If it's in front of the buccal groove between the premolar, then it's class 2. If it's behind it, then it's class 3. I mean, if you just think of the lower molar, you know, either for ideal, then you have class 2, your molar came forward. In class 3, your bottom came forward. So here's class 3, and we can't see the molars. Here, well, here's a molar. He's missing a let's see, no, he's not missing a he's probably missing his first molar here. But anyway, you can see the lower jaw is prognathic, is prominent. So something like this. Okay, so your angle here is going to be reversed.
How
Okay.
do they correct that?
Huh?
How do you correct that?
They actually break the lower jaw. So they do a split jaw back here by the ramus. They make a sagittal split, and they wear braces, and they move all the teeth into position, and then they just slide the jaw back, and then they wire him shut till he heals. But I mean, that's a lot better. He's still a little prominent. You know, here's the chin, and we're still going this way. You know, meso would be here, and maybe a little bit further back, but it's a lot better than this. And you'll see that a lot on, you know, usually Asian people. It's really common. Question on meso, retro, prog. Okay, overjet, that's just the space of your upper anterior teeth and your lower anterior teeth. Ideally, you want, you know, a 2 millimeter overjet. So it's the horizontal distance that exists due to protrusion of the most anterior maxillary incisors to the facial aspect of the lower incisors. So if these are your upper incisors looking at them sideways, your lower incisors should be right here, just touching, just on the lingual, just barely, okay? So here's the overjet. The overjet, here you've got the lower, the upper. So here you should have about a 2 millimeter overjet. That's the ideal. Okay? And we measure this with a perio probe. And we'll put the probe here and measure this. If you have something like this, okay, this guy would be, what would this guy be as far as the classification in the occlusion?
Class 2?
Class 2. So retrognathic, right? Because his chin's going to be back, everything's going to be back. So good. So here, if we put a perio probe, we're probably going to be measuring, you know, 10, 12 millimeters versus ideal 2. Okay. So that's the overjet. That's the horizontal measurement from here to here. Overbite, it's the vertical measurement. Okay, overbite is the vertical overlap. So overjet is front to back. So like this. Overjet is this. Okay, if you're the vertical. So this is the horizontal, this is the vertical. Okay, so we're measuring this. So this guy here, I can't see any of his bottom teeth. So in my chart, I would put he's got 100% overbite. Okay, because I can't see anything. If I could, I may be able to see a little bit, maybe 90%, I would say, or 98%. Okay, now if I can see, you know, half of his tooth, here I could see, you know, about half, or 60% or 40%. That would be ideal. But here I can't see anything, so I'd say 100% overbite. Now he still has the overjet, you know, so the overjet, we can't see it here. That's this measurement. So from here to wherever his back teeth are, you put the perio probe and measure that way, and give us our overjet. Question on overjet, overbite. So the overbite is just the vertical. Overjet is the horizontal. Then that's what gives you the open bite. Okay, if there is no overlap like a thumbsucker, then you have zero overlap. You're like this. So then you have an anterior open bite, only your back teeth are hitting. Okay, so here we have a anterior open bite. Open bite. Okay, cross bite. What would a cross bite be?
The lower jaw is bigger than the upper.
Yeah, the buccal cusps of your lower molars are gonna be on the outside of your upper molars, right? So they're just crossed. Or a class 3, or a prognathic jaw, is gonna give you the cross bite. It's just when your bottom jaw is reversed. So here you have a class 3, he may be edge to edge here, I don't know. But you have a cross bite on the outside. Now here he needs surgery on both jaws, upper and lower. So they end up breaking the upper jaw and opening it. He may not have had jaw surgery on the bottom, I don't know, but they would do a Lafort expansion on the top where they actually break it, split it.
I had my upper jaw.
Expanded?
Yeah, but it didn't break it.
No.
It was for
How old? How old were you?
I don't know, maybe like 11?
Yeah.
11.
Yeah, at that age, it can still be done with they put an expander and you click, click, yeah. You just feel the pressure. I did that, my son was like this, my little guy. And so I think he was 6 or 7, and we put an expander, and every night we just turn it 2 turns. Yeah. Again, at that age, the mid-palatal suture is still cartilage. At 11, it may be fusing a little bit, so it may have hurt more. But at age 6 or 7, it's still all cartilage, so they'll feel pressure, but it shouldn't really hurt. When you crank it one, they go on. You crank it twice, they feel it. I mean, they feel the pressure, but and then you got to hold it for 6 months. So again, here, this is bilateral. Here's one on one side. You can see we'll crossbite here, crossbite, and then we get okay on this side. So on this side, the buccal cusps are on the outside. Here, the buccal cusps are, on the buccal cusps of the maxillary are on the outside. Here, we've got it reversed. So here's a unilateral, here's bilateral crossbite. Alrighty. Take a 5-minute break here while we pull up the periodont. There's more cookies up there.